brainstorm better ideas before they write. Document their writing process. Check for plagiarism and AI-generated text.
And everybody. I'd like to welcome everyone to the second day. There's been a little bit of a change of schedule, so we will start with our guest lecture and continue on with the session. And then if the family is able to join us, they'll do that at another time. So I'd like to introduce the Brado lecture, which is uh, in honor of Michael Brado. So he was born in Johannesburg, South Africa, and studied medicine there before pursuing further training in Edinburgh, Scotland. He went on to serve as the chief resident in medicine at Children's Medical Center in Boston. He came to into Toronto in 1958 and served 40 years as a staff cardiologist at Sick Kids and an associate professor in pediatrics at the University of Toronto until his death in 2008. Several physicians currently on staff at Sick Kids remember him as a skilled, compassionate clinician and a collaborative colleague. He left significant gifts through his estate to Mount Sinai Hospital, the McMichael Canadian Art Collection, and the Art Gallery of Ontario, and the Toronto Symphony Orchestra. So particularly at Sick Kids, he was very prominent, and he established the Dr. Michael Brado Fellowship and the Dr. Michael Brado Lectureship to educate future generations of experts in pediatric cardiology. So his niece, Patricia Brado, who is not able to join us today, has joined for lectures in the past and has always noted that her uncle is very interested in giving back. Indeed, his headstone reads, he cared for the children he cared for, encapsulating his lifelong dedication to children's health. So in celebration of his legacy, we will be having our Brado lecture, which is by Igor Konstantinov, who is a cardiac surgeon and director of the Melbourne Centre of Cardiovascular Genomics and Regenerative Medicine. So he'll be joining us with a recorded lecture. So he graduated at the Military Medical Academy in St. Petersburg, Russia in 1992 before completion of his cardiothoracic surgery training. He also obtained a PhD from the University of Toronto in 2004. Since 2008, he is a consultant at the cardiothoracic surgeon at the Royal Children's Hospital of Melbourne and is a full tenured professor of the University of Melbourne. He has published over 500 peer-reviewed articles, and he is a congenital editor for the Journal of Thoracic and Cardiovascular Surgery and Operative Techniques. He is a member of the American Association of Thoracic Surgery since 2011. So with great pleasure, we look forward to hearing his talk. I'm just going to cue that up. Yeah.
My name is Igor Konstantinov, and I'll be talking about cardiology through the My name is Igor Konstantinov, and I'll be talking about current trends in surgical management of children with Epstein anomaly, focusing mainly on neonates and infants. My talk is based on two American Association for Thoracic Surgery expert consensus documents. We published consensus document in 2024 on management of neonates and infants with Epstein anomaly, and this was followed by 2025 expert consensus document on management of Epstein anomaly in children, in older children and adults. Standard methodology for such consensus documents was used. We made strong and moderate class of recommendations, and the level of evidence was based on non-randomized, limited data, and expert opinion studies. Neonates and infants with Epstein anomaly. First, important terminology. Circular shunt in neonates with Epstein anomaly results from pulmonary insufficiency causing the blood to flow from the aorta to the pulmonary artery through the patent ductus arteriosus, then to the right ventricle, right atrium, to the left atrium through the atrial septal defect, and to the left ventricle, and eventually back to the PDA from aorta. The fraction of circular shunt can be different, thus creating a spectrum from hemodynamically stable patients to those in cardiogenic shock. Functional pulmonary atresia, on the other hand, occurs when there is no or minimal antegrade pulmonary flow and includes those with mild associated pulmonary insufficiency. We made recommendations regarding preoperative assessment and risk stratification in fetuses and neonates, and I will not delve into them. Those recommendations are freely available online and can be easily accessed and read. We also then focused on unstable neonates. Basically, palliative comfort care may be reasonable in neonates with significant associated comorbidities. Hemodynamically unstable neonates and those with circular shunt should have emergent interruption of the circular shunt. Neonates with Epstein anomaly who present in refractory cardiogenic shock, and those with circular shunt and hemodynamic instability and low left ventricular systolic pressure, namely less than 20-25 millimeters of mercury, should undergo Starnes procedure. A modified Starnes procedure should be now performed to facilitate subsequent biventricular repair. Intraluminal patching of the main pulmonary artery could be helpful to ensure that the pulmonary valve is not deformed by the surgical procedure. Right ventricular inflow fenestrated patch is sutured to the tendon of Todaro to avoid damage to conduction system, leaving coronary sinus draining to the atrium or to the ventricle. The latter may facilitate a right ventricular development. In stable neonates, medical trial of ductal closure is reasonable. In neonates with significant pulmonary insufficiency who are at risk of development of a circular shunt, but are hemodynamically stable and have right ventricular systolic pressure more than 20-25 millimeters of mercury, attempt at medical closure of PDA should be performed. On the other hand, in neonates who are hemodynamically stable but have inadequate antegrade pulmonary blood flow, a ductal stent or BT shunt may be considered as a first intervention as an alternative to primary biventricular repair. We also made recommendations regarding subsequent procedures following neonatal palliative intervention. Subsequent procedures following Starnes operation should include a staging toward single ventricular palliation or conversion to a biventricular repair. And it is important to emphasize at this point that essentially all patients should be considered for biventricular repair. Whenever possible, biventricular repair for symptomatic children with Epstein anomaly with or without prior Starnes procedure should be deferred until 3-4 months of age, when bidirectional cava pulmonary shunt can be safely added to unload the right ventricle. And then either 1 1/2 ventricle repair or biventricular repair can be achieved. If biventricular repair is performed, either not crack repair or the silver repair can be done. Not crack repair is preferred in neonatal period, as it is a simple procedure, and it consists of closure of atrialized portion of the right ventricle and partial closure of ASD. And if a valve is still leaking, then a Sabinin stitch can be added, which is usually very effective. The silver procedure, also known as a cone repair, is a more elegant and more anatomical procedure, and it is reserved for older children. With not crack repair, the atrialized portion of the right ventricle is plicated, and then if the valve needs to be replaced, it is important to preserve all native tricuspid valve tissue, and the valve is sutured to the tendon of Todaro to avoid any damage to conduction system. And with this procedure, biventricular repair of tricuspid valve could still be performed, and the prosthesis can be removed. In the silver repair, the valve is detached circumferentially, and very important, if there is a lack of septal leaflet, then septal leaflet can be augmented with a generous patch of fresh autologous pericardium. And it is very important to use a generous patch, as autologous pericardium has a tendency to shrink with time. And again, this pericardial patch is sutured to the tendon of Todaro to avoid damage to conduction system. This is QR code to the consensus statement, and it can be easily downloaded and read for detail. Now I present a couple of very unusual patients. This patient had a circular shunt, presented in neonatal period, 4 days old, weighing 2.8 kilograms, with severe fetal hydrops, necrotizing enterocolitis, ascites, great Ortmans score, echocardiographic score was 0.79. But right ventricular systolic pressure was very good, 54 millimeters of mercury. And this patient had a very severe form of Epstein anomaly with severe tricuspid valve insufficiency. So in this patient, I resected atrialized portion of the right ventricle, and I reconstructed the valve with a generous pericardial patch, and also replaced the pulmonary valve, which was virtually non-existent and rudimentary, with 12 millimeter Contegra valved conduit. The patient did very well. Subsequently, patient required a bidirectional cava pulmonary shunt, and now is 5 years old and asymptomatic. a neonate with aortic atresia, double discordance, and Epstein anomaly. This patient was 1 day old, weighing 3.6 kilograms, with severe Epstein anomaly and a severe apical displacement of a tricuspid valve, aortic atresia, hypoplastic aortic arch, atrioventricular and ventricular arterial discordance. Palliation has been discussed, and the problem with this patient that he had a deviation, severe deviation of the ventricular septum to the morphological left ventricle, and the patient was in low cardiac output. So in this patient I performed Norwood Starnes operation, and subsequently bidirectional cava pulmonary shunt at 3 months of age. Currently patient doing well and awaiting Fontaine with normal left ventricular function. But those are extreme examples of severity of Epstein anomaly in neonatal period. Neonate with large VSD and Epstein anomaly. This patient was 28-day-old, weighing 2 kilograms. Severe Epstein anomaly, severe tricuspid valve insufficiency, and large anterior muscular VSD. In essence, this patient had a large left ventricle to right atrial shunt. So what to do with this patient? Is that okay to do Starnes procedure? But with 4 millimeter fenestration, it would be still quite significant left ventricular to right atrial shunt. Or close VSD and do Starnes operation. Or do complete repair. And this patient had persistent severe supraventricular tachycardia and severe distension of the right atrium due to this persistent left ventricle to right atrial shunt. So here you see a very large atrialized portion of the right ventricle, and this is coronary arteries here. So it is not exactly clear what to do with those patients. Of course, one could close VSD and do Starnes, or do Starnes with or without fenestrated tricuspid valve closure and leaving VSD open. So I elected to do biventricular repair in this patient, and now I expose tricuspid valve, and in a minute I will demonstrate what tricuspid valve looked like. And here I essentially run an abbreviated video to demonstrate what it takes to perform this procedure and how much time it takes. So basically, once the tricuspid valve is exposed, this is anterior leaflet of tricuspid valve, and the rest is virtually non-existent and very rudimentary as expected. So basically in this patient I perform a not crack type of repair so that anterior leaflet of tricuspid valve will act as a single leaflet, and the rest of the annulus will be plicated, and I will also close a ventricular septal defect. And you see how large is atrialized portion of the tricuspid valve is here, and atrialized portion of the right ventricle. You saw a glimpse of the coronary sinus a minute ago. And essentially, this valve will need to be reduced half in diameter. Now I make incision in the apex of the right ventricle to expose the apical muscular ventricular septal defect. And this is a very efficient way to close ventricular septal defect, as it would be not accessible through the apically displaced tricuspid valve in this small neonate. Now incision is made in the muscle of the right ventricle so that the ventricular septal defect can be exposed. And trabeculations will be divided in a minute, and this gives very good exposure to ventricular septal defect. As you see, this is a large VSD right here, and it is very easy to visualize, and ventricular septal defect is closed with glutaraldehyde treated autologous pericardial patch, and a pledgeted ranitidine suture is used. And this technique resulted in effective closure of ventricular septal defect in this low birth weight neonate. And following the closure of ventricular septal defect, now the right ventricular wall is closed, and I close it with double proline running suture. First suture is through the endocardial surface, and the second suture through the myocardium and epicardium. And then I put some TCO on it, and this incision never bleeds. It's very good. Now I put this very large size Hegar dilator, and you see the normal size of tricuspid valve in this patient would be about 13 or so millimeters. So I essentially need to reduce the annulus half. So first I put pledgeted suture at the ostium of the coronary sinus. And once the suture is placed, then I will identify the anterior leaflet, and the suture will go laterally to the proximity of the anterior leaflet, so the non-functional orifice of tricuspid valve will be closed entirely. And then, as this non-functional orifice is closed, the atrialized portion of the right ventricle will be plicated. And of course, in this small patient, the tissue are very fragile, and one would not perform cone repair. So now I put size 13 Hegar dilator, and I close the non-functional portion of the tricuspid valve. Now the suture, the plagiated suture, first plagiated suture is tightened, and the valve is essentially separated now into two orifices, and then the non-functional orifice is closed, and the atrialized portion of the right ventricle is plicated as this closure is performed. And as you see, it is a simplified procedure, and plication of non-functional orifice and atrialized portion is now will be done, and the tricuspid valve repair will be completed. And then following closure of this non-functional orifice and plication of atrialized portion, ASD will be partially closed, and part of the right atrial wall will be resected in standard fashion. And as you may see, this procedure is not technically difficult, and it can be performed by any reasonably skilled pediatric cardiothoracic surgeon. The water test is performed and demonstrates that the valve is competent, and now atrial septal defect is partially closed. And I believe it is, of course, would be very important to leave ASD here, a small ASD, and this is 5 millimeter Hegar dilator that is placed through ASD, and a couple of stitches are placed to partially close it. And of course, Gore-Tex membrane could be placed as well with a fenestration in it, if desired. And then the resection of free wall of the right atrium is performed to decrease the size of very dilated right atrium. Postoperatively, patient did not have any arrhythmias, as there was no persistent supraventricular arrhythmia as compared to before surgery, and the patient was weaned off from cardiopulmonary bypass without any difficulty, with adrenaline at 0.03 mics per kilo per minute as the only inotrope. Echo demonstrated good biventricular function and good flow in the pulmonary artery, no tricuspid valve insufficiency. So unfortunately, this patient later on developed neurological complication, and the care was withdrawn. All the children, congestive heart failure, cyanosis, significant left ventricular dysfunction, left ventricular ejection fraction less than 40%, severe cardiomegaly, persistent arrhythmia, increase the risk of morbidity and mortality. If feasible, cardiac magnetic resonance imaging is recommended for comprehensive assessment, namely assessment of right ventricular, left ventricular volume, and fraction of tricuspid valve insufficiency. Asymptomatic older children should undergo exercise stress testing with measurement of oxygen consumption to unmask exercise intolerance. We also made a recommendation in our 2025 consensus statement regarding indications and surgical recommendations for intervention. Surgery can be beneficial in asymptomatic patients provided that valve anatomy is favorable for repair. Surgical intervention at 3 to 5 years of age is reasonable, again provided high probability of successful valve repair. Bidirectional cava pulmonary shunt is reasonable when there is severe right ventricular dilatation, right ventricular dysfunction, right atrial to left atrial pressure ratio of 1.5, or failure to separate from cardiopulmonary bypass. Tricuspid valve surgery is not recommended when there is irreversible biventricular systolic dysfunction. Transcatheter closure of ASD is not recommended when there is severe tricuspid valve regurgitation or a severe form of Epstein anomaly. And concomitant MACE procedure is reasonable when there is paroxysmal or continuous atrial fibrillation. And of course, a complete set of recommendation is again available online and could be viewed. In conclusion, in neonates and infants, risk stratification is essential in neonates and infants with Epstein anomaly. Palliative comfort care may be reasonable in neonates with high-risk features. Unstable neonates with a circular shunt should have emergent interruption of the circular shunt and are commonly palliated with the Starnes procedure. Stable neonates should undergo ductal closure. Those with inadequate pulmonary flow may have ductal stenting or a systemic to pulmonary artery shunt. Subsequent procedures following Starnes procedure should be a single ventricular palliation or conversion to a biventricular repair. And it is very important to consider every patient for biventricular repair. It is not that every patient should have biventricular repair, but every patient should be considered for biventricular repair. In older children, the introduction of the Kohn procedure has revolutionized surgical management, and it provides excellent outcomes and durability across a wide range of anatomical variations. With excellent durability of current repair, the timing of intervention, especially in asymptomatic patients, will likely shift in preschool years. Comprehensive preoperative evaluations, including exercise testing and arrhythmia assessment, are critical for optimizing surgical outcomes. Bidirectional cava pulmonary shunt or the MACE procedure may be beneficial in complex patients. Thank you very much for your attention.
Thank you very much for that talk. So we're going to move our discussion on to after our next speaker. And so I'd like to invite up Dr. Alex Flo. He's one of our cardiac ICU staff physicians. He has he's been a staff physician at the Hospital for Sick Children and is an associate professor in pediatrics at the University of Toronto. He gained both his medical degree and his residency. He gained his medical degree at University of Toronto, went on to complete residency in pediatrics at McMaster, and then he returned for his fellowships in cardiology and critical care here at Sick Kids. His interests include inflammation and metabolism following cardiopulmonary bypass and nutritional delivery for critically ill children.
Thank you very much. Need to do something here.
And then you click this button. You're good to go.
Excellent. Thanks very much. So good morning, everyone. Well, thanks for the organizing committee for inviting me to talk to you guys about the management of Epstein patients following surgery. And so obviously, I'm not going to repeat all the surgical options that we just covered, but I wanted to put up a schematic in terms of what the pathway for someone who was live birth could be. And as we learned, they could either go down a biventricular physiology from the outset or down a single ventricle physiology, and recognizing that each patient will likely not have a single surgery, but will go down a multiple interventional approach in order to get to their final pathway. So then the question then becomes, well, how do we treat these patients in the postoperative period? And my disclosure is that there is limited data out there that I could reference. And so we're going to go through what's available at the different stages, and then move on from there. So why don't we look at the first stage, where the patient's born, and the decision is either to go down a single ventricle pathway with a Starnes procedure or a BTT shunt, or whether there's an attempt for tricuspid valve repair. We know from a series of papers by Dr. Freud, where they followed a cohort of patients from their fetal circulation to survival from hospital discharge, you can see that there's clear delineation of their pathway throughout this journey. What we're most interested is that middle part. How do we get from cardiac surgery to survival? And that is the one area that is poorly described. And how common is this? This is a paper which is still in preprint, which is basically using data from the FIS database. And it's looking at the initial approach to Epstein's over the last 20 years in all the hospitals with that contribute to that database. And you can see that there's some variability over time. The green is the patients who underwent BTT shunt. The purple are those who underwent tricuspid valve repair, and then the Starnes procedure is in yellow. So you can see the variability within that group. But here we're starting to get some idea of what their post surgical outcomes can be. And again, this is very high level. We're not talking about the granular details of what happens in the ICU, but in general, in this group, regardless of what type of surgery they had, they spent a lot of time in hospital, a median of nearly a month. You can see that those who underwent the Starnes procedure actually spent the most time in hospital. by a significant amount of time, which is over a week. These patients were ventilated, and they were ventilated for a long time. So the percentages which are in the brackets are those for prolonged ventilation, and those who underwent a Starnes and a tricuspid valve repair were 90% of those patients were ventilated for longer than what we would anticipate. Those who underwent an aortopulmonary shunt were still less than 90, but still three-quarters of them required prolonged ventilation. Postoperative ECMO use is not uncommon, approaching 20% in the Starnes group. And you can see that there's still an ongoing, or what I would consider an exceptionally high risk of postoperative mortality. Now, yesterday you heard all about preoperative care, and we recognize that these patients are vulnerable, and therefore there's a lot of morbidity that can be accrued in the preoperative period. And this slide is just to mention that any morbidity that you start to develop in the preoperative period will translate following bypass and following a long surgery. And so we can't divorce the preoperative care from the postoperative outcomes. But can we influence the outcomes, or are the outcomes baked into the underlying anatomy? What we learned from this paper from 2 years ago is that those who underwent the Starnes repair actually had increased mortality compared to those who underwent a tricuspid valve repair in this group. Now, this is a group of only 15 patients, so recognizing again the limited scope of some of these case series. But what we did learn after that is that one of the highest predictors in this small group of mortality was actually the lactate in postoperative day 1. So effectively, if my gleaning of this study is that if you can get by through surgery and through the immediate postoperative recovery in good hemodynamic state, then your risk of mortality goes down. And that's where our efforts come in. So what are goals of care? And from an intensivist perspective, they're pretty simple in terms of scope. You want to make sure that you have adequate cardiac output. You want to maintain adequate oxygenation, and that will vary depending on the physiology that come in. You want to make sure that you can ventilate the child. And if you come in with an open chest, ultimately the first step is to work towards chest closure. So how does the initial operation actually change your hemodynamics? I'm presenting the last study in a series of papers which explore the function of the right and the left ventricle, both following birth and through the initial palliation. And what this group, which included patients from Alberta, from Michigan, and from Colorado, showed that patients born with Epstein's or severe tricuspid valve dysplasia have poor left ventricular function, but that can change with the initial step, particularly if they undergo a Starnes procedure. And so this is the data for the LV performance following a Starnes. The Starnes are in the dark dashed lines. The biventricular repairs are in the lighter gray. And what you can see is that following a Starnes, you have an increase in your left ventricular end diastolic volume. So you have better preload into the left ventricle. You have improved global circumferential strain, and all sort of leading to better left ventricular performance. And so that's going to be beneficial. And why is that? Well, the thought is, and this was depicted nicely in an editorial by Dr. Bitterman and Dr. Friedberg from our group, is mainly thought to be due to ventricular-ventricular interactions. So as prior to the repair, prior to the Starnes, you can see over here the atrialized portion of the right ventricle. During diastole, that septum shifts into the left ventricular cavity, decreasing your left ventricular volume and left ventricular preload. And then during contraction, that part of the septum bulges into the right atrial segment and decreases your overall output. That is corrected or improved upon when you actually undergo a Starnes procedure. So that's all beneficial. So is it all dandy once you come out? And the answer is no. Again, with a lack of data, I had to go back to our own institutional experience to try to discern what are the main issues and what sort of frequencies do we actually determine this. Now, this is not peer reviewed, but and there's no comparison here, but it does give you some understanding of what the issues are postoperatively. So over a 12-year span, this covers 13 patients, 10 of which underwent the Starnes procedure, 1 a BTT shunt, and 2 who died, one due to compromise, 1 with redirection and care. And so these are the main postoperative complications and issues that we've had to deal with in the ICU. Prolonged ventilation, 83% of those who went on to survive. Arrhythmia, cardiothoraces, delayed sternal closure, and then a number of GI complications that we'll speak to. So why do they have long ventilation times? Well, mainly because they have poor lungs. And we know from the fetal data that the lungs are underdeveloped, they're smaller, and it's due primarily to a large heart that is taking up that space during lung development. And they follow that with either the cardiothoracic ratio or a ratio of observed over expected lung area or a lung heart ratio. And the data in the literature is actually pretty conflicting. There's a paper out of New York, Columbia, which says the median time to extubation is 4 days, which is actually very reasonable following a single ventricle palliation. But as I mentioned earlier, the data from the FIS databases shows that they had prolonged ventilation times as well. In our patients, in our hand, the child who underwent the BTT shunt was extubated after 2 days, but those who underwent the Starnes procedure were intubated for at least 17 days and up to over 3 months with a median of 52.5 days. Now, I don't have the comparison in terms of how it compares to other single ventricles, but I can tell you my perception and overall data I would suggest that is quite prolonged. The other important fact to this is that it doesn't include the non-invasive positive pressure ventilation, which is actually very common that these kids receive following extubation. So it's an important issue to consider. So how about arrhythmias? Well, 54% of our survivors had arrhythmias, and you can see in red the frequency within our group. So heart block of various types, first degree heart block is seen in 40%, and that's across the literature. They also develop right bundle branch block. But postoperative complete heart block is also a recognized complication, and Dr. Konstantinov sort of alluded to that in his talk a number of times. But there's also reasons for other arrhythmia, supraventricular tachycardia, either through a manifest or a concealed pathway. And we'll hear more about the manifest pathways later on. Atrial ectopic tachycardia and atrial flutter are also very common. Because of the atrial stretch, the number of incisions in the atrium, and also contributed by the overall sickness of the children. So why are they at risk for complete heart block? Well, it's because the diagram, the picture on the left shows a normal heart with the star here being the AV node sitting just at the apex of the triangle of Cox, right below the tendon of Tordaro and where the tricuspid, it's the septal leaflet of the tricuspid valve should insert. Now, along the right here, you can see an epstenoid heart, and as they put in the patch that excludes the right ventricle, you can imagine how you could potentially damage that AV node and lead to complete heart block. So that is a recognized complication. So what if you make it through the OR and you're in a fragile state? Well, a lot of our patients do get necrotizing enterocolitis. It's unclear. I saw no literature that connected this directly to Epstein patients, but we know from general literature of necrotizing enterocolitis following cardiac surgery that it is associated with severity of illness. There is no clear association with depressor support or feeds, but it all comes hand in hand. And we did see it commonly in our patient population. What I was a little bit surprised at seeing, but in terms of the numbers, but definitely have experience, is the degree of chylothoraces that we see in these patients. The exact etiology of this is unclear. It could be because of poor right-sided compliance and congestion. It can also be associated with thrombosis in the larger venous system. But it was common in our population, and this manifested with prolonged chest tube drainage. Now, the treatment will vary depending on our institution. Here I'm sharing what our pathway is, which includes a stepwise approach. But it'll include periods of NPO, steroids, or use of octreotide. Again, it'll change by institution, but the important part is what the investigations that have to be associated with that. You need to rule out whether there's associated thrombosis in the venous system. You may want to ultimately catheterize these patients, particularly if it's prolonged and incessant. And some may require a lymphangiogram to better delineate the exact etiology of the chylothoraces. For us, we remove chest tubes after drainage drops considerably, and that can be quite some time for many of our patients. Growth is a big problem, and these are just some of the growth curves that we've seen over the last 10 years. You can see that early malnutrition or caloric deprivation is common. So for those who don't often see growth curves, this lower line here is the third percentile. You would want kids to be growing between that and the upper line, which is the 97th percentile. And you can see that universally, they all lose weight and considerable weight following surgery. And it takes some time and sometimes months, sometimes a bit sooner, to actually get recovery. Some of these kids actually never get to or haven't demonstrated to get back up to the third percentile as they go through. So let's say you undertake a tricuspid valve repair and you come back to the unit and you're on high pressure requirements. And this is an example where the tricuspid valve was repaired. It's actually a reasonable technical outcome. You have mild to moderate tricuspid regurgitation, but you still have RV dysfunction. The pressure you're generating, which was prior to surgery around 40, but now it's down to 15 in the setting of RV dysfunction, but the LV is working well. You can see your atrial level shunt in this bottom right corner, shunting exclusively right to left. The one thing we need to be prepared for in the ICU is when we need to turn things around. And sometimes you embark down a treatment strategy with the best data available and understand and recognize when that strategy is not working. And so that's an important part, and that's highlighted here in red. So when do we have to bail from a biventricular repair to a single ventricle pathway? And so that same patient uh, was then taken back to the OR, where you can see the tricuspid valve patch placed in great position. The left ventricular function is working well. The right ventricle is excluded, and overall, that patient did extremely well. The outcome was favorable because of the close observation and the timely redirection to a more appropriate physiology for the child at that time. Now, right now, we focus primarily on survival, which is not inappropriate given the fact that the numbers show that you'll have close to a 20% mortality rate. But we do know that parents and families are interested in far more than that, and neurodevelopmental outcomes are top of mind, so to speak. So, and from a paper by Dr. Seed and his group, showed that neurodevelopmental outcomes are still pretty compromised following a Starnes procedure. So the vast majority will have developmental delays, at least at 18 months assessment, which is something which is unclear as of yet whether it's modifiable or not. So there's a lot of great data a lot of great research that's still pending. So that's the first stage. But thankfully, your patient has gone through the first stage. We're ready for the next step. And so what next? Well, as we've heard a couple times, you can either go down a single ventricle pathway, or you can go down or you can convert to a biventricular physiology. Now, this isn't meant to guide decision making, but to sort of give some highlight in terms of what are the potential implications for the postoperative care. So if we go down a single ventricle pathway, it's important to recognize that these kids with hypoplastic lungs, that problem doesn't necessarily go away. And at least in our experience, we've had many great successes, but we've also had some struggles going down a second stage. And insofar that our routine pre-op assessments haven't elucidated those patients that found it a bit more challenging. We have had kids where we've had to take down their glens because of poor flow. We've had others who have struggled more than our other patients undergoing Glen, either because of low SVC flow, SVC, frank SVC syndrome, and a higher use of inhaled nitric oxide than we've seen in our usual sort of Glen patients. We've even had one patient who's had neurologic sequelae, which we've attributed to high central venous pressures. So it's important to realize that the way you approach these patients in the post-Glen period may be quite different, with a bit more caution and some therapies that we wouldn't usually consider in the routine post-op Glen. Right ventricular dysfunction, particularly if you go down a biventricular pathway, is important consideration. It's variable and not always predictable. For these patients in a post-op perspective, it's best to get them extubated early, take away that positive pressure, decrease the afterload to the right ventricle. INO may be needed to variable amounts of time. inotropes to support the right ventricle, pressors to increase left ventricular contractility and leverage ventricular-ventricular interactions to help support the right ventricle. And there was one letter which described the pacing in order to augment overall cardiac output. So I want to describe two patients that we've had that we've gone down Starnes takedown towards a biventricular physiology to really elucidate the spectrum that you can see in the postoperative period and what you should be prepared for. Patient number one came off on epi and came down to quite reasonable settings at 0.05, was on pressors initially, but came off, was paced for junctional rhythm and had low RV pressures. That patient was extubated in 16 hours, was weaned off epi within 26, and never required any I&O support. That patient literally breathed through the postoperative period. Patient number two also did well, but the course was far more prolonged. Required higher inotropic support, much more pressor support, and much more support for pulmonary vascular reactivity and pulmonary hypertension. That patient was only extubated on the third postoperative day and was weaned off inhaled nitric oxide on post-op day 4, off all supports by day 5. And so what did we see from an echocardiographic perspective? First patient, the left ventricle was working quite well. The right ventricle was depressed. But the AV valve, the tricuspid valve had a beautiful repair with just a little fleck of tricuspid regurgitation. Patient number two, on the other hand, that you can see that the left ventricle is larger, but is dysfunctional. The repair of the tricuspid valve was wonderful. You can see in the bottom right corner that the flow into the right ventricle is laminar. There's no significant tricuspid regurgitation. But it did take a couple of days, I'm hoping this will play, for that right ventricular function to start to recover. Okay? And as it recovered, you started to see a little bit more regurgitation. But overall, it was at this point with functional recovery where the patient really turned around. And it's worth waiting for that because we know in this study that of both pre-op and post-op MRIs that following Starnes takedown to a biventricular repair, they actually do very well. Their left ventricular performance improves. They get better preload to the left ventricle. They get better cardiac output from the left ventricle. But in some patients, it may take some time. And the strategies to approach that therapy in the interim is important. This was something that I wasn't aware of until I started preparing for this presentation, so I always thought cool to share. It's really the vulnerability of the right coronary artery in the cone repair, and you can see here in the dashed line where the right coronary artery, the path of the right coronary artery relative to the cone repair. So I haven't seen any literature to suggest how common this is, but I do think it's worthwhile to have in your sort of data banks should you have prolonged low cardiac output, ventricular ectopy, or regional wall motion abnormalities on postoperative imaging. One of the things to realize, what you start off with isn't what you end off with, and this is all the different perturbations that you can have in the pathway along the way. Which was pretty striking, both down the number of people, the number of patients that ultimately ended up with single ventricle pathway, 1.5 ventricle and 5 ventricular pathway. And as Dr. Konstantinov said, one of the big areas that we need to continue to study is how the indications, the timing, of taking patients that have gone down a single ventricle pathway and when it's the right time if it's the right time to take them down at biventricular physiology, and ultimately how to prepare them for that. With that, we'll end, and thank you.
So for the discussion part, I'm not sure if Igor is able to join us online, but we'll start with just talking about some of the general points. We'll monitor the chat, so anybody who has questions, feel free to put them in. And if you're in the auditorium, please use your mics just so everyone can hear online. So I think, one of the first things that I always note with Epstein's is that decision making is probably the biggest thing, and it's very difficult. And one of the things that we didn't really talk about today would be how we actually manage some of the older children. And when we go out about going through a cone repair versus tricuspid valve replacement, especially as you move on into the adult spectrum. And so I was just curious in terms of perhaps if Osami or the De Silvas want to talk about, what's the decision making when we look at some of the older patients, sort of the teenagers or the young adults.
Well, what we learned from Dr. Da Silva's yesterday's lectures, you almost never replace the valve, right? So in our practice, at least, as long as left ventricle functions reasonable, I know there's, the RV function in sort of young adults or middle-aged can be quite difficult, but as long as LV functions reasonable, we try to repair those valves until they're in the 50s. Not sure you want to comment on that.
I want maybe to make a comment about, should I make a comment about the operation shown too? Can I? Yeah. When to replace the valve? In I think in older patients, for example, if we have a bad anatomy of the RV with displacement of the tricuspid valve, would be type C and D or Carpentier, it's very uncommon to have that. But if we have that situation, then a patient older than 30 or 40 years might be better to replace the valve to avoid dysfunction of the right ventricle by immobilizing the leaflet. So that would be a consideration. If the surgeons think that the mobilization will cause some ballooning of the anterior leaflet, anterior wall of the right ventricle, should consider to replace the valves. In children, we never replace under 30 years of age, and I don't think this could be possible if the surgeon failed to repair the valve, then you can replace the valve. Is different from like the operation monocosp type of operation that were done before, where they replaced the valve in over 50% of the patient children, and that children at average mean age of 7 years, and that is not a good thing because I have to replace the valve many times during the lifetime. So so basically, we do it in older patient or when you fail to repair the valve. But in an experienced center should be a very, very low number of cases, except for the older patients.
To replace the valve, you should not touch the leaflets underneath. First, to not disrupt the mechanism of holding the RV wall. And the second, to give the opportunity for the patient to shrink the size of the heart and later on consider to do a valve repair in a specialized center. So there's a possibility to do repair after replacement, like we showed yesterday, and that's the reason to keep the leaflets there. Even if you try to do the repair was not possible, keep the leaflets underneath and position the valve there.
The audience at all? Wait.
Anything that we could pick it up and improve upon?
The truth is, I don't know. I think so. I just need to talk a bit closer, I think. The, to be honest, I don't know because the studies right now that I could find really just talk about survival. Very few actually mention how long they even spend in hospital, time to discharge. And these are sort of simple like ICU outcomes that we follow. Um, so I'm not sure, but I think it's worthwhile looking into. And I do have an idea in terms of how we can do that to leverage current collaboratives and databases to see what that variability is. Um, but I don't know where we stand compared to others at the moment.
Um, I have a question for you. You showed that the stars compared with the BT shunt, the neurological outcomes were worse with the stars. Was that correct?
The It's not a comparative with the BTT shunt, but the neurologic outcomes following STARNS is less than normal, meaning they have
Okay.
developmental delays.
But that could be related to the illness of the baby because the patients
Correct.
submit the stars, they could suffer in the fetal life in the neonatal period and not relate to the procedure itself. It's more related to the type of patients. So they are the survivors because of the stars. So
Correct.
right?
Correct. It's not meant to be causative. It's not causation, but it is a finding. And so the question that that I would ask myself in looking after these kids after surgery is there anything that we can do in the postoperative period that could modify that relationship? And that's unclear. It's unclear in the general sort of neonatal in the neonatal surgical group, but this seems to be a subgroup where improvements would be really beneficial.
Yeah, I agree.
Just I want to make a comment on that too, because I saw that we start with some heart blocks, bundle block. If we place the patch over, I mean, in supraannular position, then the chance of having arrhythmia is very little because you don't affect the branch or the AV node. I saw in one of the drawing, the echo was an echo result in where the patch was very low in your drawing. It was inside the ventricle. So that's not the position that we recommend. So the other thing is, I agree. Maybe the type of patient could be a lot different because, for example, if the patient is stable, like 20 days, the only problem a low O2 saturation. So you can stent the ductus, or you can put a shunt without going on the pump. So if the RV, the the STARN is more effective when you have a patient and where the right ventricle is distended, is dilated and compressing the left ventricle. And those patients that are doing badly, they are in shock. Um, I think about neurological problem could be more frequent because you put on the pump to do that. But by doing that, you can correct the arrhythmia too. If it has bundle, not bundle, if you have a WPW, for example, you can correct it, and you can put a line of abrasion between the cave and the annulus that will add ischemic ablation, and that could prevent atrial fibrillation too. So there's a advantage and disadvantage of doing the STARN, but usually the results are better if you have the matched group of patients. That may question if you have the chance to look at that, if the patient age, for example, were the similar.
The as I said at the beginning, you raise really important and valid points. I This isn't a study that's published or anything like that in terms of the data that I'm showing you from our institution is really just is just sort of the on face data. There's no comparison, but that would be an important next step to understand how it does compare to other kids. The other piece that you mentioned, which is extremely valid, is the fact that injury is a continuum. And so that injury could have started in fetal life. And for all the reasons that were already discussed in terms of circular shunts, even in the fetal period, the extremists that these kids can be born with. And as the talk that Dr. Kirsch gave yesterday, in terms of the important implications of the immediate preoperative management, need for mechanical support. All all these are factors that can contribute to patient injury and brain injury, and could ultimately lead to neurodevelopmental compromise. So that's quite important. In terms of decision making, in terms of when to use the STARNs, when to go down biventricular pathway, it is complex and or can be complex. Sometimes it's really easy because when the patient is born in conditions where they're an extremis and the RV isn't able to generate pressure, it's dilated. It seems pretty obvious that going down the Starnes pathway is the right choice. And they're equally, if the right ventricle is generating good pressure, has decent is a decent size, and there's some antegrade flow, then trying to go down a biventricular pathway seems equally as an easy first step in terms of the management. The gray is where some kids live, and decision making around that can be complex.
Okay, thank you, and congratulations for your presentation, especially for the results that you had here with the cone after STAR.
Oh, so we have a question from Roxanne Kirsch.
and the fact that we're kind of in that extreme lens. So I think that it just becomes a difficult thing to understand what the right decision is if you just look at what happens postoperatively, which I'm not suggesting you implied, but I'm wondering a little bit if you might agree that one of the things that you can glean from those two situations, similar to other populations, is once you realize what the strategy should likely be, you have to move there quicker and not spend a whole bunch of time in decision making. What should we do land for the patients that you sort of just described as I was about to ask my question. If you know that you need to go to the Starns, get there fast so that you have less implications afterwards. And I would assume you kind of agree because we work together, but if you want to talk more about that, thanks.
No, thanks. So I see two different things from this data. Post-op outcomes, as described here, should not be used as a reason to go down a single pathway. This is descriptive, and I think the decision making to go forward in terms of which pathway you choose is based on the realities of the patient. And the quicker you can make that decision, the less morbidity that you'll incur getting to the OR, and the less morbidity you have going in, the less morbidity hopefully you'll have coming out. Where I find the importance of this data is really your expectations, not only for the team, but how you counsel parents. Because if you know that you're going to have a patient with a STARS, particularly if they're going in with significant compromise, part of the discussion that I would want to have with my patients would be in the post-operative period, this is what we would expect. And recognizing the variability that exists inherent in any patient management, I think it's important for parents to understand that if you're going in as a compromised STARS, the likelihood is that you will be in the ICU for some time, that you'll be attached to a ventilator for some time, and that along the way, there may be some struggles to talk about feeding, growth, because these are things that not only are important to us as providers, but these are things that are really important to the families as they go through the journey. And so the better that we can prepare them, the smoother it's going to be for them as they go through it. That's where I see the value in this data.
Thanks. My scene. Oh,
Okay, I would like to make comments like Jose said about the heart block that surgeons should avoid, but the surgeon also should avoid laryngeal recurrent nerve lesion. Like we had a patient that we did a con after start. She came to us with bilateral vocal cord paralysis, and that would influence the long term. Another thing that in the post-op, we need to think in the right or left shunt that will happen with the 1.5 ventricle repair or the Fontan procedure. And that could, like, we need to be careful in any procedure to avoid air entering in the lines that could cause posterior neuro damage. So those are the things that it's a teamwork to avoid the long-term complications and improve the outcomes.
No, that's great. I hadn't seen recurrent laryngeal nerve as being an issue, so that's good. I'll personally now also be on the lookout for that because that's very helpful. Thank you.
And our patients in Pittsburgh, that we have now 20 con after stents, and most of them were extubated in the OR after the con. In the con after stents. Just 2 patients that had the prolonged tracheostomy, they would be on the ventilation. That the other one that had bilateral vocal cord paralysis that we keep maintained intubated for a period of time. And another one that was intubated for like 12 hours, but most of them, they are extubated in the OR, and that improves the function of the right ventricle, as you said. Congratulations.
Well, that's great. The it's good to learn from these things because part of it is not just how you come out of the OR, but how do you prepare for the OR,
Mm-hmm.
patient selection, timing, etc. So
Mm-hmm.
there's a lot to learn from.
I think
I think
you'll
the
just have to.
issue of extubate earlier and is depend on the patient. Had only two patients, so that doesn't mean much. But normally we can extubate a little earlier, and the philosophy of the anesthesiologist group to extubate on the room most of the patient, and they were able to do with the cone after start. Uh, but I want to make a comment about Igor Konstantinov presentation. Not about his presentation because he's not here to answer, but about the present or large VSD in combination with Abst anomaly. So how would manage it? So normally, may I do this? Is okay to? Yeah, so is normally you if there's a large VSD, the patient's still alive, mean that he has some tricuspid competency. Otherwise, it will be an example of circular shunt too, because the VSD shunts to the atrium, to the ventricle, right ventricle, and then regurgitation to the atrium, the ESD, and then it will be a different type of circular shunt, but it will also affect the cardiac output. And so it's very serious. But if the patient is born alive and is decompensated, it's very important to close the VSD and whenever possible, close it through the atrium because then you can avoid arrhythmia and you're already dealing with RV that's not normal. Um, and then if you can have a technique to do the tricas valve, if you have a simple technique that is effective, fine, it can be used to. But some techniques like the Hatzer that put heavy suture in the septum and bring the anterior leaflet, anterior annulus to the septum is in Hatz publications associate a higher number of heart block. But anyway, if you manage to do it in a safe way, you simplify the technique. Is a good way to go. I agree with that. You don't need to do the cone. But if you cannot do the repair, you can also do a Starn procedure. In this case, you can have the option to leave a little fenestration, the VSD, and close completely the annulus. We have done this in patients that came from outside with multiple VSD, and they put a patch over the tricus valve and then repaired and did a pulmonary bending, which is an option. So that's the reason for me to make those comments because there are many options that you can do, and I think it's important to discuss those options. I don't know if Igor is available. He could comment on that if he's online.
Yeah, he's not online as of yet. I think it's close to midnight where he is now. But I would agree. I've been avoiding a ventriculotomy would seem like a good approach if you can do that.
Actually, we had the second patient last week that I did the con after stat that came from Poland. Also, two patients from Poland with a VSD that they did the stance without the fenestration, and then later on we did the con after stand and closed the VSD. So,
So you wouldn't do the full repair in this patient that Ego presented.
It was a
Just
No,
stage them with a
no,
stand.
I think that I didn't know the clinical situation.
it
I
was
know
a
that the patient didn't do well after the operation, but I don't never know because we don't know the details. But yes, there is indication to close the VSD if is pulmonary overflow. You can do that. If the valve is incompetent, then you have to deal with that too. And the way to deal, I think the easiest way, especially patient, surgeon, they're not very familiar with the repair of tracheal valve is to do, for example, to put a patch and bend. If the RV is too dilated, then might be good to close the VSD as well. So I probably will close the VSD, but I'll try to do through the tracheal valve. That will be the difference. And then how to deal with the other valve depend on the situation. It's a simple repair. I am maybe I will do it. I used to do it that way. So, but the mortality was a little higher than when we start. But this is very special situation. The very few cases available. So I cannot give an idea how to do. I can give some ideas, but I don't know specifically in that case what I would do. Probably I would close the VSD like he did, but try to do through the atrial though.
Thank you. I think Dr. Seed had a question.
Thank you. Yeah. Just getting back to your comment at the beginning, Rachel, about older patients, and it was, I think, the part of the program where I was hoping we might tackle that a little bit today. Around the question of repairing the tricuspid valve. As when I started practicing, we used to wait until the patients either became cyanosed or they had atrial arrhythmias or exercise intolerance, and used to be repairing patients as teenagers or adults with very dilated right ventricles, and it feels like we're coming down in terms of age, and that was commented a little bit yesterday. We heard on the guideline, the best time to do that is maybe 3 to 5 years of age, but I'm also hearing some patients are getting done earlier. So I was hoping we could have a little bit of discussion around that topic. And then the other thing that I read in the literature in preparation for the meeting was, that occasionally a heart transplant is the right treatment for Ebb's gene anomaly. And I wondered if our distinguished guest might comment a little bit about that question.
So I think the first question is about doing a younger age, right? Yes, I think if the patient is cyanotic, we haven't seen, we have had very good result. After 3 months of age, we haven't lost a patient in the hospital. So for that, so we can go, we can do it a little early. But I think any surgeon can do it if they're 10 months older and has a good experience doing the cone. I think the result will be very good. And the reason to lower the age, I think the patient that need to lower the age are those that you have RV dilation, cyanosis, or severe tricuspid regurgitation, or arrhythmia too that you cannot control. So those are classic indications. Of course, if you have some surgeons have managed the cyanosis with a Glenn procedure, and that's possible too. We have seen also patients that come to us with a stent, but it's hard to tell what will be the result of that. That's the issue with Epstein. Being a rare disease, it's hard to evaluate the risk and benefit a different approach. But in our institution, I think we can do a young age if we need. And regarding doing a patient that has no much symptom, but had a bad anatomy. He had like a patient, like extreme rotation of the tricus valve with the valve, some of the elements of the valve attached and near the pulmonary valve. And then those cases, if you do early on, uh, the operation will affect the ventricle, the RV function, but will be affect a little less, and then they have time to grow. And as the patient grow, probably the chance of recovery of the right ventricle reverse remodel is better. That's why those type of those anatomic types of severe abstinence anomaly, I don't think it's good to wait. And many authors try to do them. We try to do them like when they are 15 months. They do the first birthday, and then we do the operation, and the risk is not high, and then the chance for recovering the RV is better. Now, if you have a moderate or a mild abstinence anomaly, and that you think require has other feature that require operation, then you can do a little later. Can be 3, 5, 7 years of age. That does not matter much. But they start dilating the RV, then it change again. Then you have to intervene a little area. Now, regarding the indication for transplant, um, well, if we have dysfunction of the right ventricle, I mean, of the left ventricle, yes, you need transplant instead of then you have to deal with the left ventricle problem. Then you you need to do the heart transplant. We had a case where was operating another institution that had a very dilated right ventricle and had a gland already, and the patient cyanotic. So we did the cone, improved the trachea valve. The cyanose didn't improve much because she had the AVM. And then, unfortunately, the RV didn't recover much. So the group in the other hospital decided not to take down the gland. That would be a way to try to recover from the AVMs. But the patient was like 10 years old, around 10 years old. So they consulted us on that. We discussed the case. We kind of agree because it would be very risky to take down the gland in that situation. So with experience, the cone after Starn, we might have different ideas. But if you have cyanosis, then it's hard to do because you have to reverse the situation, maybe try Starn, and this is something that we are still thinking about. And if we find the right patient, we can do that. Yeah, and in my experience too, we had a case in São Paulo, Brazil, where we had a lot of arrhythmia and dysfunction. It was a girl that came late to the operation to be operated. I saw her indicate to operate, and then she deteriorated uh, the LV, but not that much. And the right ventricle was very enlarged. So we did the cone, and then she was doing fairly well, but she started having arrhythmia, ventricular arrhythmia. And then we put an ECMO. We correct the arrhythmia by eliminated the atrialized area that was the source of arrhythmia. But then she didn't recover the function. And then we got an organ, a heart that was small for her. So we did it a heterotop heart transplant. We put she had a gland already, so we removed the gland and put her the pulmonary artery of the donor in the right and the place of the gland, and then we connect her cava, the superior cava, to the superior cava of the donor, and the other part of the atrium we just suture. So it became a heterotop heart transplant, and that was done about 12 years ago, and she's alive and she played tennis. So the heart, her own heart, the left ventricle has recovered. The RV doesn't look good. So now we don't know what the next step is. if she haven't recovered her own heart, we can remove the transplanted or implanted heart. So those are the situations.
Can I just ask a brief question about, as we're doing the conversion from Starnes to a cone procedure earlier, do we have good longitudinal data in terms of what happens to the tricuspid valve following the cone and how well that grows over time?
Yes, if when I used to do newborn, that was associated with higher rate of reintervention because of the tricuspid regurgitation. But at that time, we didn't use any patch. And now in younger patient, I don't, a younger but like older than 3 months, more often 6 months or over, we haven't had much problem with the valve. But still, we can have problem with the ventricle itself. If they are dilated, have a bad anatomy, and then I know of a patient that we didn't do, actually two patients that we didn't do the gland initially because it looked good, and then they came back to do the gland. One was done out of our institution, and the other one was done by us. Uh, and then we are watching that. We did the gland, and also we did the Starn procedure, and then we see what's going to happen in the future.
Great. Those are valuable insights. Did anybody else have any other questions? No? I guess I had one just, we were watching the video from this morning, and it brought up sort of, what's within our surgical kind of capabilities, how do we treat concomitant lesions when we're dealing with an Epstein's, and, they showed a Norwood with a Starnes patch, and, kind of getting towards, what is too much surgery early on, and, when do you pivot towards palliation? I don't know if, Roxanne is a great expert in these discussions, but also the De Silvas and sort of their experience with these, neonates who might be premature in extremis, but also have concomitant lesions. How do you sort of go about those decisions?
I think they were we're sort of wondering, is it ever hopeless to operate and better not to do anything in a newborn?
I think the earliest stance that was performed by our team in Brazil was 34-week old, 2.1 kilos, and the patient had a circular shunt. That was the reason she was born prematurely. But in Pittsburgh, we do not have many cases of neonatal starts. Most of the patients, they were born in other institutions. And of course, we need to deal with the prematurity, the risk for bleeding in the head and other things like that. And other comorbidities that can happen. But it's a difficult decision when not to offer anything for those patients. And if they are very sick, we can try to do a PDA stent if there is pulmonary atresia. But if they are in like low cardiac output, there is no way out without doing the STARTS procedure. So we need to balance the risk of prematurity, low birth weight, and the STARTs.
I also remember of a case in Pittsburgh. That's one, I think, was the only one that we didn't do because he was born prematurely and had brain some brain damage. So if you have neurological deficit or bleeding, then of course that would be a contraindication to do anything. And then, but we had a case that was placed on ECMO, and then with that evaluate, you have the chance to evaluate the brain. If the brain is okay, and then you can go ahead and do the con, not the con procedure, you can do the Stern procedure. That was done, and the patient now is in the kindergarten. She has no neurological issues. So the ECMO can maybe help making the decision when, especially if the family is very interested in saving the baby. It's very valuable for them for certain circumstances. And then I think start with ECMO can be helpful if you have issues, I mean, with the indication. And I saw a paper by Dr. Starnes when he operated a patient very young, 1.5 kilos. So the issue here is how to do the shunt. So what he did a central shunt with a long, a long conduit. Is a 3.03 millimeters and long conduit in the central shunt because it's hard to do anastomosis in the subclavian of the brachiocephalic artery, and so that would be an option to. But those are rare circumstances.
Thank you, Roxanne. Yeah.
Yeah, so I think it's always a difficult thing when you exist in the place that needs to push the envelope for the opportunities for future patients and figure out what is the best thing for an individual patient or family. So in a few broad sweeping ways, one part is that the fetal teams are quite good at starting the counseling early. And I think that makes a significant impact to how the family has opportunity to make choices and decisions and think about views and values and be able to share those with the team so that you understand what might make sense. It becomes important to make sure that families know that you're providing care, whether you're doing an interventional pathway or a non-interventional pathway. Obviously, the duration of the life or the time in the ICU may be very different depending on how you go about things. When you're at the extreme end of the Epstein spectrum, then obviously that conversation becomes more apt as to whether it's appropriate to even offer. And I try and get us to split a little bit because I think it clarifies, at least in our minds, how to figure out offering. There's the I can do this, and I think it's a terrible idea as a clinician because it's almost certainly going to go wrong, but I'm not so certain that it will be wrong and totally harmful that I wouldn't be willing to proceed with it, so that you can then counsel the family in the we would be able to do this and we would actually recommend not doing this for this reason. And you will really understand then a family who's very valued in a big shot swing for the fences, but may be able to then counsel appropriately to understand that you have to back away when that doesn't work or try and set them up for that. But it also gets the team on the same page as to how confident you are. And if you think you're more like, actually, I'm not sure this is going to turn out well. I feel pretty pessimistic about it, but I think we can do it. And I think there's a reasonable chance that we can maybe get someplace better. And we're in small percents. Then you're also counseling for you happen to be in a place where we can do things that are pretty aggressive. And the sequelae of all of these aggressive interventions are these multiple problems. So it would be very reasonable and we would accept not proceeding. However, we would be willing to give it a try for these reasons in this patient. It's a lot of nuance and some sweeping statements there, but I think it kind of puts you in a few different categories of how you actually can partner with the families in that piece of what is actually known and unknown. But you do have to try and consider that just because, we're pushing the envelope and let's do a snazzy new thing, or we can maybe make this work, there's still a life at the other end that has to take on the burden of all of the things that we do. So if you really are crossing a threshold of certainly only doing harm and very unlikely to ever achieve any benefit, you should really reconsider and not offer at all is the most appropriate. But when you're stating things like, we don't think it's appropriate to offer surgical intervention, or there isn't an appropriate surgical intervention, or there's no longer an appropriate thing to do, that you are able to stay partnered with the family to provide ongoing appropriate, high quality end of life care and transition, because the abandonment that can be felt in saying, well, we can just do nothing, or it's hopeless, is really profound for families and makes it almost impossible to accept the reality that might be in front of everyone.
Thanks, Roxanne. So I think this ends sort of the portion for this first part, and we'll take a break and come back for session one. All right. If there's no further questions, then everyone can go and get some coffee. Thank you.
Testing. Hi, good morning, everyone. Welcome back after break to the first session on arrhythmias in the pediatric and adult Epstein's anomaly of the tricuspid valve population. It is my absolute pleasure to chair this session, and we have two excellent local speakers, the first of which is my colleague and dear friend, Dr. Yuval Bitterman. Dr. Bitterman is a staff pediatric cardiologist and electrophysiologist at Sick Kids in Toronto. He is also an assistant professor of pediatrics at the University of Toronto and a principal investigator at the Sick Kids Research Institute. Dr. Bitterman's main research focus is electromechanical dyssynchrony, arrhythmia mechanisms, and the lifelong care of congenital heart disease patients. Please join me in welcoming Dr. Bitterman.
So thank you so much for the kind invitation to give this talk, but also the introduction. I don't have any disclosures. And we're going to talk about what I think is the most fascinating, well, I'm an electrophysiologist, so I have to say so, the most fascinating part of Epstein's anomaly. And we're going to go over arrhythmias, and specifically in the pediatric population. And as Dr. Ed Walsh put it beautifully, Epstein's anomaly is basically a natural laboratory for reentrant tachycardias. So with that in mind, we will start and talk about the common arrhythmias in the Epstein's anomaly. We'll talk about the concept of pre-procedural electrophysiological studies, and then we will talk a little bit about outcomes and the challenges in treating these arrhythmias. And we'll start with a case. So this is the case of a 17-month-old female who came to her doctor because of a murmur and was referred for an assessment with cardiology. And I just put up her ECG here. And there are three things that are quite evident on this ECG. And the first one is that you can appreciate these very large P waves here, indicative of right atrial enlargement. It's also pretty clear here on V1. The PR segment is not prolonged. We'll go back to that afterwards. And then in terms of the QRS itself, it's wide for age, but it doesn't have a morphology of a clear right or left bundle branch block. Also another feature that we will discuss a bit later. She, as part of her evaluation, she underwent, and this is not an echo talk, so all of these are still images. You can see here clearly the location of the tricuspid valve leaflets that are very displaced, and the severe tricuspid valve regurgitation, and there's also an atrial communication that is shunting mostly right to left. The ventricular function was preserved. So this is at 17 months of age. And then a few months later, she presents to the emergency department in this tachyarrhythmia. So you can see and appreciate that there is a tachyarrhythmia here, a tachycardia. Interestingly, it doesn't have a very, very clear P waves. You might imagine some maybe in the nadir of the T wave here in a sort of a mid-RP relationship, or you might even think that maybe there is something here just before the next QRS, so a long RP relationship. And the morphology itself is different now. It's a right bundle branch morphology. This was already treated with vagal maneuvers and responded very beautifully, and then had a quick recurrence that was treated with adenosine. So further evidence that this is a reentrant arrhythmia. And eventually, the differential diagnosis that includes aberrated, we'll call them as a general term SVTs, so AVRT with aberration, AVNRT with aberration, or all sorts of other arrhythmias. And this was treated very well and controlled very well with medications. But at 3 years of age, because of her hemodynamics, she requires a cone procedure. And at this point, I think I would ask myself three questions. So first of all is, how common is this association or situation in which you have a patient that has Epstein's anomaly, but also suffers from arrhythmias? The second is, what is the electrophysiological substrate? Because that will obviously indicate what we need to do with it. And then how do you go about assessing those patients and about treating them, and what do you get? What are the results of these things? So Epstein's anomaly has a strong association with supraventricular tachycardias as a whole, and mostly pathway-mediated tachycardias like atrioventricular reentrant tachycardia, but also AV nodal reentrant tachycardia. Intraatrial reentrant tachycardias, which are macro reentrant tachycardias in the atria, are also quite common, especially if you talk about a lifelong perspective later on in life, because of a combination of stretch and scarring and also repeated interventions on the atria that create all sorts of interesting lines of block. And two other things that are not as common but are important clinically. One is ventricular tachycardia, which is also thought to mediate some of the sudden cardiac death in Epstein's anomaly, usually a reentrant one. And then focal atrial tachycardia like EAT, which can also happen in the context of Epstein's anomaly. In the pediatric world, 10 to 30% of patients will develop some kind of an arrhythmia during their childhood. So quite an important association. And for the most part, these arrhythmias are going to be pathway mediated. So what is the substrate? As I just said and alluded to, the pathways are the main substrate for the arrhythmias, and 10 to 40% of patients are estimated to have an accessory pathway, at least one, and about half of the patients have multiple pathways, which complicates things quite significantly, as we'll see. It's not uncommon to have dual AV nodal physiology, which is the substrate for AV-NRT. There is also a tendency for Maheim fibers, which are fascinating, but not the subject of the talk today. But those are also more common in patients with Epstein's anomaly. And intraatrial reentry, which I already talked about, is something that does exist and is quite common and also becomes more troublesome as life goes on. And macro reentrant ventricular tachycardias are very rare, but they are important clinically because they can be very poorly tolerated and even, as I said, lead to sudden death. So with that in mind, when we think about accessory pathways, obviously the comparison to the usual or classical quote unquote Wolff-Parkinson-White comes to mind. And interestingly, there are quite striking differences between the two situations. And first of all, at the outset, there's a different prevalence. So if in the classical Wolff-Parkinson-White syndrome, about 1 in 1,000 in the population has an accessory pathway, in Epstein's anomaly, it's quite significantly more common. In terms of the ECG signs, they can be very, very baffling. So if you're looking for accessory pathways, you're thinking about that trio, that combination of a short PR, a delta wave, white QRS morphology. But actually, in Epstein's anomaly, things are different. So first of all, the PR does not have to be short. It can be just normal. And because it's starting off with some prolonged PR at the outset. So it might be actually normal and not short. You don't always see delta waves, as was the case over here. And your QRS can actually be narrow. And that is because there is a baseline right bundle branch block morphology. And when you have an accessory pathways, most of them are sitting on the right side, they can actually shorten the conduction through the ventricle. And we'll see that again in a few minutes. And then in terms of substrate, Wolff-Parkinson-White patients mostly have a single pathway. Some of them do have more than that, but it's not that common. And on the other hand, Epstein's patients have, about half of them have multiple pathways. And in terms of the arrhythmias, your regular run-of-the-mill SVT or atrioventricular reentrant tachycardia actually has a different property to it. So when you're looking at it, it can actually have what we call a long RP relationship. And that is also due to that longer conduction time, and it takes it longer to come back into the atria and create the P wave. So quite baffling to look at sometimes. In terms of the hemodynamic effects, while in Wolff-Parkinson-White, barring rapidly conducted AFib, usually these arrhythmias are very well tolerated. They're a nuisance, but they're very well tolerated. Epstein's patients, even with modest increase in heart rate, these arrhythmias can be very significant to their hemodynamics and not well tolerated. And now we can go on and talk about the concept of pre-cone assessment with an electrophysiological study. And this is, I will preface and say that this is a growing level of evidence or growing body of evidence. But when one considers whether it's reasonable to do such an assessment, you have to consider that these patients have a high prevalence of treatable electrophysiological substrates. So it would make sense to go in and try and create and treat those before issues arise. And also, nobody wants to go into a newly repaired tricuspid valve after all of these beautiful operations that we saw from the Silvas. You don't want to go with a catheter there and risk rupturing something or ruining that beautiful repair and then having torrential TR and now needing to go back into the OR. And lastly, and importantly, maybe you can't even get there after the surgery because maybe somebody did an annuloplasty or there is some invagination of tissue or scarring above the area where the connection lies, and you won't be able to ablate it even if you want to. On the other hand, anybody who's ever taken an Epstein patient into the lab knows that, first of all, these patients are just physically small, which increases the risk of complications and also decreases your chances of succeeding in their ablation. So that is one challenging thing. And the second challenging thing is that they do not tolerate their arrhythmias. Even pacing them is not well tolerated. So you have, when you're going through this exercise or when you're starting to take these patients, you have to take that into consideration. We usually do in our center invasive monitoring with an arterial line. We prepare differently. We do shorter bouts of pacing. We don't let them stay in SVT too long because these could be quite risky actually if you do them in a cavalier fashion and just let them do whatever they do during the study. And this is just an example of one case series from about 12 years ago already, looking at pre-operative assessment. And what is interesting here is that even the patients that did not have any rhythm concerns prior to surgery, a lot of them actually had some electrophysiological substrate that was of importance and needed addressing. In this case series, I'll just say that they also did a ventricular stimulation protocol, which is not our usual practice here. And this is still an open question, but as you can see here, preoperative assessment has importance and can find a lot of interesting, important, and treatable substrates, even if the patient has never had an arrhythmia. And this association with accessory pathways is not new, and I just put one picture here from one of the first studies from the 70s. It's been known for a long time that these patients tend to have accessory pathways. Where do these pathways sit? So for the most part, they're in the posterior region, either posteroseptal, posterior, or posterior lateral. And this is one of the first series from 1996 looking at that, more from the fluoroscopy era. And this is a more contemporary one from the Boston group, where you can see that it's exactly the same spots along the right-sided AV valve. And it's important to note that it's very, very rare to have an accessory pathway on the left side of the heart. And in these two cases where there were cases of an accessory pathway on the left, it was actually in the context of a congenitally corrected TGA with an Epstein-like or Epsteinoid valve on the left side. So in the usual quote unquote Epstein anomaly, if there is such a thing, those pathways sit on the right side of the heart, which is important when one approaches this. But it's definitely not all rosy. These studies are challenging. And the technical challenges, we can divide them into three groups. The first challenge or group of challenges is electrophysiological. Anybody who's ever looked at electrograms from these patients know that they're very challenging to look at. They're very fractionated and low amplitude in the atrialized right ventricle. The second thing is that the muscle orientation is different. So these fibers that go diagonally sometimes change the signals also. And lastly, as I said before, a lot of these patients have multiple accessory pathways, which are always more challenging to diagnose and to get rid of. Anatomically, everything is not the usual way. Everything is dilated. It's really hard to know where the true atrioventricular groove is. And there's also a ridge tissue in that area, which makes it challenging to navigate your tip and to keep it there and to be stable there. You can't do all sorts of fancy maneuvers with your catheter sometimes going into the ventricle because it's very much displaced and not where you're ablating. And be mindful that the AV groove tissue, while there is a ridge there, it's also very thin around it. So you're very close to the right coronary artery, as I'll show you in a picture in a second. So there is an increased risk for coronary artery injury. And lastly, hemodynamically, as I've said before, they're intolerant to SVTs and pacing, so you have to be quite cognizant of that when you're doing the study. And they also have right to left shunting, which increases your risk for thromboembolism. So all of these patients need to be treated with some form of anticoagulation during the procedure and after. And these are just pictures to show you what I just said. And you can see here the ridge along the true AV groove and the highly displaced leaflets of the valve from this histological specimen, and over here, basically the same thing, but just with a picture from fluoroscopy. And this is that ridge that I was talking about. You can appreciate quite nicely where the coronary goes and how close it is. And this is just an intracardiac echo picture. And lastly, these are the electrograms. And if anybody here in the audience, and we have people here with much experience in EP studies, if you see this thing in an otherwise normal heart, you would never go for this place. This is not a good signal and you're not sitting in the right place. But in an Epstein patient, this could be actually fantastic as an AV groove signal. So how do we do with all of these challenges in mind? So using the same group, the Boston study that was recently published, if you look at 61 patients who underwent this assessment and ablation for accessory pathways, acute success is pretty good. The problem is that about a third of them had recurrences. However, if you take those recurrences and you bring them back to the lab, or if you take them for surgery, you can probably get rid of most of them. So if you look at the eventual success, you had 6 patients who died from non-arrhythmic reasons. And if you deduct those from the 61, basically 53 out of the 55 could be treated with a combination of ablation, maybe a redo ablation, and surgical intervention, which is not bad in this complex anatomy. However, importantly, there is a significant era effect with recurrence risk. So if you compare the patients who underwent procedures at an earlier age, possibly because of different techniques and understanding of the situation, they had a lot of recurrences. And if you take the ones that were done relatively recently, they have pretty good results. Not in the realm of usual ablations, but pretty good. Other contributing factors, so fluoroscopy-based versus electro-anatomical mapping use. There was a trend, numerically it was important, it didn't reach statistical significance, but definitely makes things a lot easier to understand where you are and what you're doing. Age was an important factor, so age less than 2 years was associated with more recurrence. And this is important, as the De Silva said, when we're contemplating taking these patients earlier and earlier and earlier into the surgery and wanting to do these before the surgery, we just have to be mindful that this will decrease significantly our chances of success and will increase the risk for complications in the procedure, in the preoperative assessment, and weight below 15 kilograms, which is sort of like a line in the sand that we always use as a weight that we would really much appreciate being above in terms of risk for complications, and also success rate was also found to be associated with recurrences in this patient group. So essentially, if you compare the classic series, like the one that I showed you by Caparo et al. From 1996, where everything was fluoro-based, the procedure time, the mean procedure time was 7 hours, so long. And the fluoro time was 70 minutes, so more than an hour of fluoroscopy. They had about 60% recurrence rate at that point. And if you compare it to the more contemporary techniques such as electro-anatomical mapping and intracardiac echo to know where you are and to look at the signals in a different fashion, you have decreased procedural times, and also the recurrence risk is already getting slightly closer to the usual risk of recurrence in other procedures. Considering this anatomy, it's not that bad. So circling back to our case, this is the map that we got, and you can see here, to the ones that don't look at electro-anatomical mapping, that there is a right lateral accessory pathway that was ablated. And interestingly, this is the ECG after the procedure. And because this is pretty small, I've just enlarged it for you. And you can see that this was the pre-operative ECG, and this is the post-operative ECG. And now you can see a couple of things. So the P waves are still big. There's right atrial enlargement. This has not changed. But the PR segment is now long, or normal to long. And the morphology of the QRS has changed into a right bundle branch block, which highlights the point that we all know that whenever there's an Epstein patient without a right bundle branch block, a complete right bundle branch block, you should suspect that maybe there is a pathway there. So to conclude, accessory pathways are strongly associated with Epstein's anomaly. They're almost exclusively on the right side, and a lot of times there are multiple. The ablation is complicated, and it's complicated because there are multiple pathways, the anatomy is challenging, and the electrocardiograms are very abnormal. But the ablation prior to surgical repair is critical, especially if you think that you're going to lose the access to the AV groove. with the procedure itself and should still be something that you should do prior to the surgery. And that was it.
Excellent. Thank you, Dr. Bitterman. That was an excellent overview of arrhythmias in our pediatric population. We'll reserve the questions to the end of this session. Our next speaker is another excellent local colleague, Dr. Krish Nair. He is the program director for cardiac electrophysiology at the University of Toronto for its 3 fellowship programs and the fellowship program director at the University Health Network. Dr. Nair's clinical and research focus is on ablations and devices in adult congenital heart disease. He's on the editorial board of the Journal of American College of Cardiology Advances. He has initiated several interventional EP programs at the University of Toronto, including baffle punctures, transhepatic punctures, as well as programs addressing physiologic pacing like left bundle branch area pacing and the leadless pacing program. Please join me in welcoming Dr. Krish Nair.
Good morning. Thank you for the opportunity to present here. My topic is adult arrhythmias in Epstein's anomaly. It's my disclosure. So I'll attempt to discuss this topic by going through the following subtopics. We'll talk briefly about conduction system anatomy, pseudonormalization of ECGs in Epstein, accessory pathways, and the importance of identifying the tricuspid annular plane, atrial flutter in some specific post-surgical situations, atrial fibrillation, and ventricular tachycardia. And I apologize because there'll be some overlap with the UL slides too. So it's a busy slide. So regarding conduction system anatomy, there are only 2 things to remember from an electrophysiologist's perspective. The triangle of Koch is smaller. What that means is that the vertical distance from the conduction system where the His bundle or the AV node is to the coronary sinus ostium is reduced. That is important because we burn around the coronary sinus ostium for slow pathway ablation AV and RT. The other important thing to know is that the AV node may have inferior extensions that go down all the way to the level of the cavo tricuspid isthmus. That is the space between the inferior vena cava and the tricuspid valve. So you should be careful when you ablate in this region. The number of features of a typical ECG in Epstein's anomaly. The P wave is usually large and called the Himalayan P wave. The PR interval is prolonged, not because there is AV conduction system disease, but because the right atrium itself is dilated and there is delay in interatrial conduction. The QRS is broad because of RV dilatation. And typically you get a fragmented QRS, which indicates a greater atrialized ARV, more of the atrialized right ventricle. There's RV conduction delay because of 2 reasons. One is obviously delayed activation because of the utilized RV, and 2, a hypoplastic right bundle itself. So this is a patient with Epstein's anomaly, and you can see fragmentation. Not very typical of Epstein, but the fragmentation leads us to suspect that this could be Epstein, and this is a conventional right bundle branch block. So the important features, just repeating myself, is right bundle branch block with fragmentation. So typically, what happens if this is an ECG of our patient, very similar to the ECG which UL showed. There's no right bundle branch block here. You get an RS in V1. So if you know that a patient has Epstein's anomaly and the patient has SVT, but the ECG does not show right bundle branch block, there's a very high chance that there is an accessory pathway. And the accessory pathway location is likely to be in the right free wall region. We already know that. We have not touched the patient. We already know that. So if you look here, this is typical Epstein. This is a patient with right bundle branch block without any accessory pathway. You get right bundle branch block. If you have a postroceptal pathway, which is a common type of common location for pathways in Epstein, you still get pre-excitation. you get a negative QRS, a negative delta in V1. But if you have a right free wall pathway, you get a pattern like this, just like this, the same ECG which he showed. And that's because in right bundle branch block, the right free wall gets activated late. In a right free wall pathway, that the free wall gets activated early. So they neutralize each other and you get this pattern. So this is a list of arrhythmias in Epstein. There's some typical for Epstein and some which we see in any adult congenital heart disease. So you have a higher incidence of axillary AV pathways, what we call the Wolff-Parkinson-White type of pathways, the atriovascular pathways, what we call Maheim pathways, and then AV and RT, which can happen in anyone, monomorphic ventricular tachycardia, which I'll come to, and atrial flutter, which is the commonest arrhythmia which we see in across the street. And as the population grows older, we see more and more of atrial fibrillation. Polymorphic ventricular tachycardia can occur in any heart which is dysfunctional. And of course, these patients are also prone to sudden death. Without repeating what Yuval said, essentially, accessory pathways in Wolff-Parkinson-White are almost always on the right side in the posterior and posteroseptal region. They're often multiple, and they have the usual characteristics of these AV pathways. They usually conduct bidirectionally, which means they go forward and backward. And you can get both orthodromic reentry, which means a tachycardia which involves the AV conduction system in the antegrade direction and the axillary pathway in the backward direction. You get a narrow QRS. Sometimes you get antegrade